morning, everyone. A warm welcome to all of you who joined. My name is Dr. Chul Kim. I'm a thoracic medical oncologist at Georgetown University, and I'm honored to be your moderator for today's educational webinar titled Management of Autoimmune Disorders in Patients with Thymic Epithelial Tumors. Organized by the International Thymic Malignancy Interest Group, ITMIC. And so we are aware that thymic epithelial tumors pose several challenges, including autoimmune disorders that can affect a significant portion of patients with thymic epithelial tumors. We are honored to host three distinguished speakers today, and each a recognized expert in the management of thymic epithelial tumors and its complications. And so they have agreed to share their insights and updates about autoimmune disorders in thymic epithelial tumors. To maintain a smooth progression, we will have a dedicated Q&A segment at the end of the presentations, and throughout the talks. Please do not hesitate to submit your questions via the chat function. Alternatively, you can voice your questions during the Q&A session, and your active participation is highly encouraged and valued. So it is my pleasure to introduce our first speaker of today's webinar, Dr. Henry Kaminski, who is the Meta Amalia Newman Professor of the Department of Neurology at the Georgetown Washington University School of Medicine and Health Sciences. As we all know, Dr. Kaminski is an internationally recognized expert in the care of patients with myasthenia gravis and neurological complications associated with thymic epithelial tumors. His research focuses on understanding the biology of the extraocular muscles and the pathogenesis of myasthenia gravis. The floor is yours, Dr. Kaminski. Thanks for joining this morning.
Okay, so I think we share something in common, regardless of who we are. We don't know enough about thymic malignancies, and we certainly don't know enough about the autoimmune diseases, specifically the ones affecting the nervous system. And honestly, the more I think I know, the less I actually know. And let me dive into this. So as this is very focused on patients, I'm going to give you a very broad introduction. Hopefully that might help other speakers. So first of all, let's talk about the immune system and where it is. And just in general here, there's the thymus gland, which we'll be talking about later. It's a site where a specific group of immune cells, T cells, develop. But then we have lymph nodes. Some of you have had viral infections, may appreciate that. You can feel your lymph nodes when they swell up with proliferating immune cells. But we have these lymph nodes throughout our body. The spleen is a site of where a certain group of B cells often exist. And I'll tell you, 2-3 years ago, I would have said, okay, yes, this is the immune system, but it's really everywhere. It's becoming increasingly appreciated and, known for some time, but increasingly appreciated the importance of immune cells that exist within, for example, muscle, which is, my area of interest, but also within the skin, the liver, specialized cells within the brain that are really part of the immune system. So I think it's really the complexity of the immune system is ever increasing. And oh, by the way, the central nervous system talks to immune cells. Many of them have the same kind of communication molecules that are within the nervous system, and then also the primary kind of cytokines and other chemical that is affecting immune cells affects central nervous system cells, and just recently the importance of a large nerve coming out of the brainstem, the vagus nerve going into the intestines, is a crosstalk between the nervous system and the immune system. So that's why I talk about the immune system being everywhere. It's really throughout the body. And let's then go to, what it does. I mean, I think many of us already appreciate this, is that the immune system protects us from invading bacteria, viruses, and eliminates cancers. And as we'll see, when we come to thymomas, the nervous system's attempt to respond to that tumor is one of the reasons that autoimmune diseases can be triggered. And there's two basic types of responses. One that is antibody driven. These little Y-shaped molecules are attaching here to the coronavirus spike protein. At least there's a cartoon of that. That's one system. And then there's cellular responses that occur in response to, again, bacteria, viruses, and cancers. So the immune system responds in different ways. And just to continue to go through that, there's the division of the immune system traditionally has been into two versions. One, the innate immune system, which is evolutionarily the oldest and considered rather non-specific. Now, as you'll see as I talk about this, this division is becoming increasingly blurred. There's really chemical messengers here in the innate immune system that affect cellular immunity and adaptive immunity. And so in some ways, this is artificial. The complement system, just to stop there, is a set of complicated proteins that enter and attack bacteria and destroy them. And they work with the antibody-mediated immune system that we'll talk about. There's cells that will destroy invading bacteria. And again, it coordinates with the next part of the immune system, the adaptive immune system, which is very important in that it is targeting specific invaders. And so the first innate immune system is very non-specific in its response, but this is designed to really attack known pathogens that are not self-proteins. And so this consists of antibodies and the B cells which produce these antibodies, as well as what are called T cells that can provide signals to these B cells, but also attack foreign invaders again here. And here we have this education process, as I call here. So there are tens to hundreds of thousands of different proteins that a human being may be exposed to. Some of those are part of our own bodies, and we certainly don't want the immune system to attack our own bodies. Yet we need to have a robust system to eliminate these foreign invaders, as I'm calling them. And so in the thymus gland, primarily, there are a system of eliminating cells that will react to self-proteins and educate, so to speak, the cells to attack foreign invaders. Now, yeah, let's move to autoimmune disorders, right? So I think from what I've already said, there's an appreciation that there are a need to eliminate attack on self-proteins. And so many of these autoimmune diseases I've shown here, the most common being rheumatoid arthritis. Probably many of you have heard about that. It attacks the joints, causes inflammation, and significant disability. It is actually one of the most expensive diseases in terms of cost to the US healthcare system. And that's because of the chronic disability as well as the expense of some of the treatments. So Individually and in total, these are significant disabling diseases to obviously a human being, but also to our society on many different levels. So now turning to the real primary subject of my talk, the thymic epithelial tumors, and I'm going to leave this to other individuals to talk about the tumors themselves. But from what I said, the thymus being important in the immune system, it's not necessarily unexpected that thymomas might lead to some autoimmune complications. And that's basically what I've said in this slide. So now let's move to what these are. Now, I think this is where my expertise really comes in, right? So I studied the autoimmune disease myasthenia gravis, and studies vary, but about half of patients with thymomas will have this disease myasthenia gravis, which I'll talk about. And in some of those patients, there's a degree of muscle inflammation called a myositis or myopathy, and that um, is often associated with myasthenia gravis, although it can be difficult to distinguish how much is the myasthenia and how much is the inflammation in the muscles. Now, all the other autoimmune diseases of the nervous system associated with thymoma are exceedingly rare. And even this inflammation of the brain, and I'll go through these briefly, um, occur exceedingly rarely. And so, but they have very broad presentations. So encephalitis, one sees confusion, memory loss, change in speech. If the inflammation is in the brainstem, one will see um, difficulty with eye movements, double vision, but also swallowing difficulties in the absence of any cognitive problems. And then spinal cord, one can become paraplegic or quadriplegic, have loss of sensation in the legs or arms, but really intact cranial nerves, intact facial features, ability to speak is normal, and the cognitive processes are normal. The basal ganglia is very important for movement, and so patients may have completely intact cognition, memory, speech, but they have difficulty moving. They may have abnormal movements, and so walking becomes difficult, reaching for um, pen or really any object becomes difficult. And then sometimes it can be very specific to individual cranial nerves so that one gets a loss of movement on one side of the face. And the cerebellum also is very much involved in movement. And so abnormalities, movement. And so all those put together, though, are less than 1%. Neuromyotonia is a disease of the nerve muscle communication, more on the nerve terminal side. The autonomic nervous system controls blood pressure and sweating. The important thing here is to patients out there, these are extremely rare situations. And so it is very difficult, as we'll see, to be able to tailor treatment specifically to any one of these. And then further, because this is very hard to study these, to be able to understand what the driving force behind every one of these diseases, and also to be able to tell you about a prognosis in each one of these. But I'll get to that a little bit later. So now let me focus on myasthenia gravis. This is a disease of nerve muscle communication. And so any voluntary muscle is affected. So some of these images here, it's very common. Nearly every patient will have either droopy eyelids that fatigue. And so one can be completely normal in the morning, and then by 2 o'clock or with prolonged activity, the eyelids droop to the point of essentially being functionally blind if both of these eyelids droop. Facial muscles can be affected. So this person literally cannot close their mouth. They're trying to close their eyes tightly, but you can see their eyelashes, and so that's weak. Um, you can imagine somebody not being able to move their facial muscles will look depressed, even though they may not feel depressed. And so there's the kind of emotional impact of the disease and people not really being able to express themselves in these nonverbal ways. And to really get a sense of what patients experience, there's an Italian woman who's also a cartoonist and an artist more generally, who's depicted her life with myasthenia gravis. And you can see here, she becomes exhausted because the hallmark feature of this disease is that with increasing activity, one gets increasing weakness. So one gets the ocular, the facial feature problems, but it can cause general muscle weakness of the legs and the arms, may become difficult to even comb or wash one's hair, and ultimately to breathe, and a patient may need to be hospitalized, placed on a breathing machine. So the symptoms and the signs of myasthenia gravis vary considerably across patients. Um, but and now let me turn to what the problem here is. In terms of a thymoma, the immune system starts to attack proteins um, within the tumor in response, as well as surrounding tissues. And these antibodies form, should you picture those little triangular shaped um, molecules, and they begin to attack the nerve muscle communication point. So this is a normal nerve terminal. This is the muscle surface. It's got these undulations, which are very important for its functioning. But then this is a nerve muscle junction from a patient with myasthenia gravis. So you can see the nerve terminal is still there. There's some subtle abnormalities we don't need to talk about, but all those folds here, which are critically important for transmission of the nerve signal, are lost. And so that's the basis of the weakness, and this varies across these nerve muscle communication points. So that's the underlying etiology of the signs and symptoms of the disease. Um, now, harking back to the initial discussion of the immune system, there's a great deal of complexity in the development of myasthenia gravis. So this is a cartoon here of this nerve muscle surface and the antibodies that attack these acetylcholine receptors. That's the key protein that is normally expressed on the muscle surface, which is actually over here. I'm sorry, and the um, the contrast that there is this programming error that suddenly the immune system, because of the presence of the tumor, starts to attack this acetylcholine receptor. Now, why myasthenia gravis itself is so common in thymoma patients is not well understood. Um, there's some theories that really I don't think we can establish well. But these antibodies are produced by these B cells, which are now within the area of the thymus, but also have distributed themselves to the bone marrow and lymph nodes throughout the body. So even with removal of the thymus and the thymoma itself, one doesn't cure the disease, as I'll discuss. These other components of the immune system are key to giving signals to these B cells to produce these antibodies, and how this cartoon here is meant to represent how the actual protein or acetylcholine receptor like proteins are expressed within the tumor and outside of it that may trigger the disease. But again, this is not well understood. I've listed some treatments, and I'll go through those a little bit in other slides here. As you see, there are a number of targeted treatments that can inhibit these antibodies from causing injury. There are new drugs, FCR inhibitors, that are infusions that can remove these antibodies. However, these treatments down here don't stop any of the ongoing injury, ongoing processes causing the autoimmune disease. So we have other system intravenous immunoglobulin plasmapheresis that removes antibodies. We have treatments of azathioprine, tacrolimus, and mycophenolate and rituximab that can attack these systems. Prednisone, given at high doses for long periods of time, is still the consistently most effective treatment, but if anybody's been exposed to prednisone, it is also filled with complications and not something that is optimal for treatments of patients. So here's a listing. You don't really need to read through this. There's kind of two important pieces that I'd like to say. We have a number of treatments. And so there are options when one fails that one can go to another one, as long as one uses these correctly. These three agents here can take 6 months to 9 months to work before we know that they've failed. Some of these here are more quick acting agents. So it's good that we have a lot of treatments. The challenge here is that this does reflect that we don't know which one is best for the individual patient. And when you have a disease that has such a wide list, it suggests that none of them are completely optimal. But I do want to emphasize to the patients out there, we have options for treatment, and when one fails, that does not indicate the next will fail. And I've been talking about myasthenia gravis, but these agents, especially prednisone, IVIG, plasma exchange, these longer term immune suppressive agents, the azathioprine, mycophenolate, tacrolimus in particular, they can be used for all the other autoimmune diseases of the nervous system associated with thymoma that we discussed earlier. So a word about this. It is essential to remove the tumor. There's no question about that. It's a rare instance that that's not the case. And I'll leave it to my colleagues to expand on that piece. However, removal of the tumor does not cure this problem. As I mentioned, the tumor triggers the autoimmune process, and then those cells exit the area of the tumor, go into peripheral immune organs, and they continue the autoimmune process. And at least in the case of myasthenia, it can be very difficult to eliminate those. And compared to non-thymoma myasthenia, it tends to be harder to treat. Everything I'm saying here is tends to be, because there are some patients that I've had who they have a little bit of that droopy eyelid. We'd always do a CT scan of the chest or some type of imaging of the chest to identify the thymoma. This one person I just saw had it resected. 2 years later, no symptoms. She's doing great. Of note, sometimes the autoimmune disease occurs after the removal of the tumor. So it's great that at least in the case of myasthenia, can identify patients early for resection, but you're not necessarily completely home free from having this disease or other diseases after you've had the thymoma resection. One caveat again here, you don't have to put yourself under a microscope to think about, do I have myasthenia gravis? You will appreciate that something is wrong. So don't become hypervigilant looking for any of these diseases. So in terms of myasthenia gravis, once effective treatment is identified, we stop the autoimmune process, one can return to completely normal functioning. I mean, when I tell my patients about this, I say 99% because I can't guarantee 100%. And the treatments may also produce weakness, but the underlying problem of the muscle injury is generally reversible. Now, with these other conditions of the brain and spinal cord, it is more difficult. We don't have the broader evidence base for understanding of the pathophysiology of myasthenia of these diseases, and so we can't target treatments as effectively. We don't have enough experience here to understand the longer-term consequences, and then depending on the area of the brain that's affected, the symptoms may not be reversible. So I know that that's not a very satisfying answer to some of you, but they are treatable once identified. And despite the toxicity of the treatments we have for these autoimmune diseases, it's definitely possible to improve somebody who's suffering these devastating autoimmune diseases. And with that, I just want to acknowledge our research group here at GW, and I will exit out and turn over to my colleagues.
Great. Thank you very much, Dr. Kaminski, for your presentation. We now have the privilege to welcome our next speaker, Dr. Arun Rajan. Dr. Rajan is a senior clinician in the thoracic and GI malignancies branch at the National Cancer Institute, National Institute of Health. He's my mentor. He trained me to be an oncologist. As a leading expert in the field, Dr. Rajan's clinical research related to drug development for thymic epithelial tumors is well recognized. He has conducted numerous clinical trials evaluating various biological therapies in thymic epithelial tumors. One of the many recognitions that Dr. Rajan is that Dr. Rajan has received the Barbara Neubauer Award from ITMIC a few years ago. Dr. Rajan, we look forward to your presentation.
Thank you so much, Dr. Kim, for that very kind introduction. It's really an honor to be part of this webinar. Let me share my slides here. All right. So thanks again for the opportunity. I hope to share some thoughts from the point of view of an oncologist about these autoimmune disorders, and the focus here would be on the non-neurological autoimmune conditions that can be seen with thymoma. I have no disclosures. So as a very brief introduction, autoimmune disorders we know are fairly common in patients with thymic epithelial tumors, predominantly thymomas. They can be observed in about 40% of cases based on the paper and the literature you look at. There are certain subtypes of thymoma that are associated a bit more often with these autoimmune conditions, such as the WHO type B thymoma. There is also a debate about the prognostic implication of having an autoimmune disease in the context of a thymoma, with some larger series, including one from ITMIG itself, that appear to suggest an improved prognosis. This is a list of conditions that can arise. As Dr. Kaminski mentioned, myasthenia gravis is by far the most common condition in association with thymic epithelial tumors. But a whole variety of different conditions can be seen. This is a paper from a few years ago, a surgical series where they tabulated the type of autoimmune conditions that were seen in their patients, and more than 100 different conditions were seen in a patient population of about 500 that these folks looked at from their institution. I would also like to point out that autoimmune diseases can occur even with thymic carcinoma. These tumors are thought to behave more like other solid tumors with a decreased propensity to autoimmune disease. But it can very well happen in that context. And as oncologists and physicians, we should be aware of that. Now, Dr. Kaminski gave a fabulous introduction to the immune system. As he mentioned, it really exists everywhere. So I'll just talk a little bit from the point of view of the thymus from an oncology standpoint. The thymus is really, it consists of different parts. There is a cortex, and then there is a medulla. And the naive immune cells that enter it during the process of development, they go through multiple phases, and essentially that leads to the development of what is known as immune tolerance, where if there are cells that react to self-antigens, they undergo cell death, and those that are tolerant to self-antigens go back into the circulation, and that essentially comprises the concept of generation of immune tolerance. This process is dysfunctional in the setting of a thymic tumor. So as an end result of that, you have self-reacting T cells that go into the circulation, and they can cause this propensity to autoimmune disease. Now, the process of self-tolerance, development of self-tolerance is really complex and I don't think fully understood, but there have been a lot of advances in understanding this process. It is now clear that the cells in the thymic medulla play an important role in the generation of immune tolerance, and they happen to generate this activity under the influence of certain genes, one of which is called the autoimmune regulator gene. And I think this is an important discovery, and I'll mention this in the context of related diseases later in the talk. Now, autoimmune conditions may not happen in isolation. They may actually occur concurrently. And in some instances, like in this case here, you may have involvement of the skin, of the hematological system. You may have other organs that are involved. And this can essentially be, in some instances, very reminiscent of the type of complications that are seen after a bone marrow transplant. So in essence, abnormal T cell development leads to changes in immune tolerance, and that in turn results in autoimmunity. Maybe just request everyone to mute themselves.
Just one sec, sorry. I think we hear a lot of background noise from one of the participant named Jay. Can you mute yourself? Or, yeah, whose name is J2. Sorry, we hear a lot of background sound from you.
Yes, stop talking.
And sorry, I cannot mute anybody because I'm trying to claim host now, but I'm not yet because I have to create the Zoom link.
I think we're good.
We're good. Okay, perfect. Thank you so much. All right, sorry.
All right, so moving on to, so we talked about the thymus, the role in generation of immune tolerance, but moving to the thymic epithelial tumors in particular, I think there's an increasing recognition that there are several different types of immune cells that are involved and integral to these thymic tumors. Based on current knowledge, thymic tumors are essentially stemming from the epithelial component. That's why they're called thymic epithelial tumors. And all thymic tumors are, that's thought to be the origin of the cancer. But the role of the immune cells is really important, not just in terms of treatment response to treatment or lack thereof, but also in the generation of autoimmunity and the persistence of these issues in the context of these tumors. So this is a recent paper which gives an overview of the sort of immune compartment, the non-malignant immune compartment in thymic tumors, and the complex interactions that occur between these immune cell subsets, which in turn lead to this risk of autoimmunity, and as I mentioned, also have implications for treatment of the thymic tumor itself. Now, switching gears and just talking about the spectrum of non-neurological autoimmune disease. This is a lovely paper from several years ago from Dr. Alexander Marks, which gives a broad overview of the type of autoimmune conditions that can be seen in association with thymomas or thymic cancers. I've just selected the non-neurological disorders here, and Dr. Kaminski had given an overview of all the neurological conditions that can be seen. As he mentioned, I'd also like to emphasize that these are rare. So most patients may not have an individual condition. They may not experience it. And there is an association with certain subtypes of thymoma. And in some cases, there is a recognition of what might be the potential cause, whereas in a lot of other conditions, it still remains poorly understood. There are, in the last 10 or 15 years, there have been further developments and recognition of additional conditions that are actually autoimmune disorders, although they may not appear to be so on the face of it. And I'll focus on one or two of them, since in the limited amount of time we have, it's not possible to describe all or most of these conditions in detail. So I'd like to first talk about something known as Good syndrome. There is a component of a subset of patients who have infectious complications and basically have a type of acquired immunodeficiency. Now, those may seem distinct from autoimmune disease, but they can actually be the other side of the same coin in many instances. Dr. Robert Good, working in the University of Minnesota back in the 40s and 50s, is credited with the recognition of immunodeficiency in conjunction with thymoma. He used to work with pediatric patients, and at one time he was referred, I think in 1953, a patient from a colleague who had what turned out to be a thymoma, and he had 17 episodes of pneumonia over an 8-year period, which certainly was abnormal. It was not a normal pattern. And from that work led to the recognition of the fact that certain patients with thymoma can have low immunoglobulin levels, and that can make you more susceptible to infection. So the infectious complication in this case is a manifestation of autoimmunity. Now, this has been proven. This is a recent paper from Switzerland, where they looked at their subset of patients with thymoma, and they found that a number of these patients have infectious complications and autoimmunity happening together. And then there are subsets of folks who may have autoimmune disease but not infections, or vice versa. And about a fifth of patients don't have any complications. So it's not necessarily a case where autoimmune disease is a constant companion to a thymoma. So acquired immunodeficiency, as I said, is increasingly recognized. We have had an opportunity to do some of this work at the NIH, and there are a lot of other groups that have done important work in this regard. I think the take-home point here is immune deficiency or a decrease in the number of cells. Immune cells might not be the only reason for this infection, predilection to infection, but there are other causes as well. One of which is what are known as anti-cytokine antibodies. So these cytokines are basically chemical messengers that the immune system functions with the help of. And when you have antibodies to these cytokines and their levels drop or they become dysfunctional, numerically, your immune cells may be normal in number, but functionally, you have an immune deficit. This is a study that we published many years ago from the NIH. We had, I think, 17 patients with thymic tumors, of which the majority had thymomas. 4 patients had thymic carcinoma. And a subset of patients, uniquely patients with thymoma, had opportunistic infections, which are those conditions that you don't normally tend to associate with a healthy immune system. When these were analyzed further, a number of patients had high levels of these anti-cytokine antibodies. At the top here are listed the various cytokines that can be that were tested. Antibodies were tested against, and you'll see some common patterns of antibodies in certain in many of these patients, and a subset of them develop these severe infections. Now, over the years, the role of anti-cytokine antibodies has come into more sharper focus. It is certainly seen in some patients with thymoma, but it can cause a lot of other issues and also be seen in associated conditions, one of which is known as APICED, which I've highlighted here. And you remember I talked about the AIR gene, the autoimmune regulator gene. This is a common shared feature with APICED, where there's a primary deficiency of AIR, whereas in thymomas, it's more of a secondary deficiency, but that's a common mechanism. And that's one thing that we have sort of focused on, because there is a strong program focusing on APICED at the NIH. So what have we learned from this? Immunodeficiency due to functional deficits due to anti-cytokine antibodies can occur in both conditions. Another example of this is autoimmune pneumonitis, which is lung inflammation in patients with rare patients with thymoma, which is also a condition seen in this primary air deficiency syndrome of APICED. Here you can have inflammation of the lungs, and that is again because you have this lack of self-tolerance, immunological self-tolerance. The symptoms can be very non-specific. They could be respiratory symptoms, cough, shortness of breath. These can, mimic infections. They can mimic other conditions of the lung, chronic conditions like cystic fibrosis, and they can cause changes on CAT scans, which are again very non-specific. You can't really point to a condition and say, that's what this represents. Now, what you also see when you do bronchoscopies in these cases and look at tissue, you see that there are a number of T cells, lymphocytes in these biopsies, which proves that it is sort of an immunologically mediated condition. And you also find certain antibodies in about 50 to 60% of these patients in the blood. So that is one way to potentially diagnose this condition if you have someone with chronic respiratory issues. Another example is this condition known as large granular lymphocytic leukemia, or LGL leukemia. Despite the connotations of the term leukemia, this is a condition that can actually be treated and managed, and patients can lead a relatively healthy life. This occurs because there are certain types of immune cells called T cells or NK cells that replicate more than they should, and they crowd out other types of cells in the bone marrow, which can therefore cause a decrease in, for example, your platelets, or cause anemia or other conditions. Now, LGL has been rarely associated with thymomas. It can be seen in the context of, pure red cell aplasia, or just by itself, where there are deficiency in hematological cells. The diagnosis can be established by various means that I won't go into here. This is a study from the Cleveland Clinic that was reported recently, 20-year experience. And you'll see among 327 patients that they had with thymoma, some of them had what is known as pure red cell aplasia, which causes anemia, essentially. Some of them had good syndrome, which we just talked about. And then a very small number, actually, 3 out of these 327 patients had this condition called LGL leukemia. So the point I'm trying to make is autoimmunity can take different forms, and it can be quite rare. So a recognition of these conditions is important, and its association with the underlying thymic tumor. So those were just a few examples. I'd like to take a moment to share with you how I think through the management of these conditions. As Dr. Kaminski highlighted, it is really important to have a multidisciplinary discussion in these cases. As oncologists, we are not really trained necessarily to treat individual immune conditions affecting different organ systems. So to reach out to colleagues who have that expertise and refer patients is incredibly important, in my opinion. So how do I look at it? If a patient comes in with a thymic epithelial tumor, or essentially a thymoma-associated autoimmune disease, I first try to figure out if the activity of the autoimmune disease correlated with activity of the thymic tumor. Is there an indication that there may be a relapse of a thymic tumor that was previously operated? Or if it was an inoperable situation, is the tumor growing? If the answer to that is yes, then generally one step you need to take is to treat the thymic tumor. As Dr. Kaminski mentioned, in many instances, you can do surgery, but in some instances, it may be an inoperable situation. So you need to think about chemotherapy or other systemic therapies to treat these patients per established oncological guidelines. If that is not the situation, if there is no evidence of a tumor, at least radiologically, or you can't discern that, then I think you need to focus on treating the autoimmune condition with immunosuppressive therapy. Now, if you have treated a thymic epithelial tumor and the autoimmune disease is controlled, that's great. Then you can just move on to surveillance. But if it is not controlled, as Dr. Kaminski mentioned, in many instances, the tumor can be removed, but the autoimmune disease can stay, then you need to, again, focus on immunosuppressive therapy. And this can take various forms. You can use non-specific drugs like corticosteroids, or you can use certain drugs that target specifically the T cells. I'm giving a couple of examples here, or the antibody part of the immune system, the B cells and the antibodies and the plasma cells, by things like intravenous immunoglobulin, plasmapheresis, rituximab, etc. As I mentioned, consultations are, it's really important to reach out to colleagues who have this expertise, and multidisciplinary management is also important because, a lot has evolved. A lot of treatments have, come into clinical practice, as we saw for myasthenia gravis, but also for other conditions. And if I have a situation where I'm dealing with this sort of issue, I may refer a patient to a neurologist, a rheumatologist, and again, other appropriate specialties, because it's a little bit outside our field of expertise as oncologists. An example of how this works. So we talked about autoimmune pneumonitis. So these folks, this is a case of APICED, where you can treat with T and B cell directed immunosuppression. You can see here, this graph represents symptoms in the form of cough at baseline and a significant improvement a month later, and resolution by 6 months. This is an improvement in the CAT scan of the same individual. These are tests done, the pulmonary function test, which shows that the drop in oxygen occurred less frequently after treatment, and patients were able to exert themselves more and walk a greater distance after treatment. Interestingly, these changes happened despite no change in the levels of the antibodies. So that is something to be aware of. You may not get an objective evidence of improvement in terms of labs, but clinically there would be an improvement based on scans and other parameters. This is APICED, but we have a similar sort of situation in patients with thymoma, which we hope to share soon. Another final example of decrease in blood counts as a result of autoimmunity in patients with thymoma. These are bone marrow biopsies where you see T cells on the right-sided panels in 2 different cases. And I put this up to highlight that steroids might not always work, as in the second case. You may need other drugs such as immunoglobulins or intravenous immunoglobulins or cyclosporine. This is something we had presented at the ITMIG meeting last year in the form of a poster. So in conclusion, patients with thymic epithelial tumors are prone to having defects in immune self-tolerance that can lead to paraneoplastic autoimmunity, which can sometimes present as acquired immunodeficiency as well. It's important to focus on thymic-directed therapy, thymic tumor-directed therapy, which can lead to resolution in some cases, but in many instances, the paraneoplastic autoimmune condition would need to be treated in parallel. And as I mentioned, immunosuppressive therapies sometimes need to be tailored. They need to be chosen carefully. And I feel comfortable, reaching out to specialists who have the appropriate expertise to help manage my patients who are facing these conditions.
It's not worth it.
So with that, I'd like to conclude, acknowledge the contributions of all our patients and their families, of the research group that I work with at the NCI, and our collaborators in different institutes of the NIH. Thank you so much.
Thank you very much, Dr. Rajan. So now I'd like to introduce our next speaker, Professor Dirk van Raemdonck, who's a thoracic surgeon in the Department of Thoracic Surgery at the University Hospitals Leuven, Belgium. Professor van Raemdonck's contribution to the field of thymic epithelial tumors is enormous through an extensive body of research. We are lucky to have Dr. van Raemdonck join us today. Dr. van Raemdonck, thank you very much for joining.
Well, good day to everybody, wherever you are in this world. I'm Dirk van Raemdonck, thoracic surgeon working at the University Hospitals in Leuven, Belgium. So this is our hospital here, and this is a staff of 7 thoracic surgeons working in our hospital. So I'm going to give you my presentation that I give to our medical students when they have a course on thoracic surgery. So let's first talk a little bit about the anatomy. And here you can see a CT scan with a transverse and a sagittal image showing you the mediastinum, and that is a space in between both pleural cavities, so both lungs, from anterior the sternum to posterior the vertebral body, and then from the top, the thoracic inlet, how we call it, and the diaphragm. And you can see here in red the thymic epithelial tumor. So we usually divide the mediastinum into compartments, either into 3 compartments, as you can see here, or in 4 compartments. But actually within ITMIC, we have now a modern definition of these mediastinal compartments, and we call them the prevascular mediastinum, the visceral mediastinum in the middle, and the paravertebral mediastinum at the back. So in this mediastinum, a patient can develop many tumors. I sometimes call this the Pandora box. So when you open the chest, you never know what comes out. And so here is a list of all mediastinal structures in the prevascular mediastinum, in the visceral, and in the paravertebral. And as you can see, there are many structures running there, and from each of these structures, you can develop a tumor. So you'll always have to bear this in mind when you try to make a diagnosis in a patient. Now, a mediastinal mass can be related to an infection, like what we call mediastinitis, but usually it is related to a tumor. And in the mediastinum, we have real tumors and benign cysts. And as you can see, the thymus usually is in the anterior. The thymic tumors are in the anterior mediastinum or anterior superior mediastinum. But we also can see false tumors, like for instance, aneurysms of the big vessels and the heart, or a hernia of the stomach into the chest. So always take in mind that this can be a false tumor. Now, also the age of the patient is important. We know that the tumor in the mediastinum will be different in pediatric population versus adult population. So we see thymoma in about 19% of all mediastinal tumors in adults, while in pediatric, we see more neurogenic tumors and lymphomas. So if we look only to the prevascular mediastinum, you can see that in children, 45 or nearly half of the tumors are related to lymphomas, while in the adults, nearly half of the tumors are thymic tumors. Now, you already heard, of course, a little bit on the symptoms that such a thymic epithelial tumor can cause, but usually it is an incidental finding on imaging. Some patients may present with systemic symptoms or even local symptoms, and you already heard a lot about the so-called paraneoplastic symptoms related to the autoimmune diseases. So this is a study by the Framingham heart study, looking at chest CT scans in more than 2,500 patients, and they found an incidental tumor here in 1% of the population who presented with an anterior mediastinal mass that was completely asymptomatic. What can be the systemic symptoms, the so-called B symptoms? Well, patients have less appetite, anorexia. They can present with weight loss, with fever, and night sweating. What are the possible local symptoms? Patients can develop chest pain, a cough, dyspnea because of compression of the tumor on the trachea. They can have hemoptysis, stridor, hoarseness when the vocal cord nerve is invaded, or difficulties in swallowing, so dysphagia. I'm not going to talk about this slide, all the paraneoplastic symptoms that you have already heard about, the autoimmune diseases. And as you can see, the most frequent one is the myasthenia gravis and also red blood cell aplasia. Now, we as physicians and surgeons, we have to follow the guidelines. And here you see the guidelines by the National Comprehensive Cancer Network on how to diagnose a patient with a mediastinal mass, what imaging to do, what markers to take, and that will differentiate whether we think it's a thymic malignancy or whether a thymic malignancy is unlikely. So what about imaging? Usually it all starts with a chest X-ray with an enlarged mediastinum. Then we can do a CT scan. We can also do an MRI and further on a PET scan to make the differential diagnosis. Here you can see a PET scan in a patient. And on top, you see a patient with an anterior mediastinal mass that turned out to be a thymic carcinoma. And what you see on the PET scan is some uptake of the radionuclide isotope in the periphery of the tumor, while the central tumor has become necrotic, so it got infarcted. And on the bottom, you see a thymoma patient. And as you can appreciate, there is much less uptake of the isotope here in the tumor compared to the patient with a thymic carcinoma. We can also differentiate it using the so-called standard uptake value of the isotope, and that can help us if the SUV is low. It's probably more a thymoma. When the SUV is quite high, then we believe it's a thymic carcinoma or even a thymic carcinoid. And also within the subtypes of thymoma like A to B2, this can differentiate with another thymoma type B3 because that has a much higher SUV value. There is always a discussion whether we need to biopsy such a tumor prior to surgery, yes or no. And we know that when you open the capsula of such a thymic tumor, you risk to have spillage that can recur in the months, in years after the surgery with so-called droplets in the pleural cavity. So if the tumor is really solitary mass that looks primary resectable, it doesn't look very invasive on CT scan, and all the tumor markers are negative, we do not make a biopsy and we go for surgery immediately without histology. However, if the tumor looks very big and invasive, we need some tissue for differential diagnosis, and certainly these patients will benefit from induction treatment, and therefore we need histology and we do a surgical biopsy. Now, the way to do a biopsy can be from non-invasive methods to more invasive methods. So we either prefer to take a biopsy through an endoscope, like a bronchoscope. We call that EBUS or EOS through the esophagus. It can be CT guided with a fine needle aspiration or a true cut biopsy. We can use cervical mediastinoscopy, an anterior mediastinoscopy, mediastinotomy. I will show that in a minute, or we can use video-assisted thoracoscopy. So this is a picture showing you how we can do mediastinoscopy. So we look into the mediastinum through a rigid tube, and this is another way of taking a biopsy of an anterior mediastinal mass by making an incision between the second and the third rib. A discussion always with the pathologist is that we should have adequate tissue to make a differential diagnosis, and the smaller your biopsy is, the more difficult it is for our pathologist. So we do not always rely on fine needle aspiration biopsy. The differential diagnosis between thymoma and lymphoma is quite difficult, so we prefer to have a true cut biopsy or even a surgical biopsy. And then we come to the different tumors, the so-called surgical tumors that benefit from surgical resection. And of course, in this presentation, I will only focus on the thymic epithelial tumors, but there are many other surgical tumors. So you've already heard about the thymus. Here you can see again the anatomy and the location behind the sternum and the morphology. So the thymus has a capsule, a cortex, and a medulla. And it consists of different cell lines, so we call them epithelium, lymphocytes, neuroendocrine cells, germ cells, and even fat. And all these cell lines can evolve into a tumor. So you can see here the different thymic tumors, and of course we will focus on the thymic epithelial tumors, or called thymomas or thymic carcinomas. This is a picture of a thymic lymphoma, which is a benign tumor consisting of fat, while here you see a real thymoma, a big anterior mediastinal mass. Usually it's in the prevascular mediastinum, but I've also seen tumors in the visceral mediastinum. And then the differential diagnosis between a thymic epithelial tumor type thymoma versus just hyperplastic thymus, like in myasthenia gravis patients, is sometimes quite difficult. A PET scan can help, an MRI can also help to make the differential diagnosis. And then from time to time, we make a misdiagnosis and we think it's a thymoma. We operate the patient and it turns out to be a thymic cyst, so a benign fluid-filled cyst. And of course, now with the new techniques of MRI, the differential diagnosis is much easier. So once again, 20% of all mediastinal tumors are thymic epithelial tumors, 40% of all tumors in the anterior mediastinum, and even 90% of all tumors in the antero-superior mediastinum. Here you can see the different types of thymic epithelial tumors. So we talk about thymoma from A over AB, B1, B2, and B3, up to thymic carcinoma. We also called it in the past type C, but we no longer use type C now. It's thymic carcinoma. Rarely we can see a thymic neuroendocrine tumor or NET tumor, and then a thymolipoma. There are different staging systems. In the past, we used a system called Masaoka-Koga system that really looked at resectability. Can we remove the tumor with surgery? We also have the WHO classification that looks at the cell type or the histology, but nowadays we use the so-called TNM classification for staging, looking at tumor, lymph nodes, and metastasis. Some pictures on the different staging system. Here you can see the Masaoka-Koga staging with the different stages from less invasive to more invasive. Here is the WHO classification on thymoma and carcinoma, and then the TNM classification with the different factors for T, N, and M. Some further descriptions of the categories, T categories, and the NM descriptors, as published here by Datterbeck and colleagues. And again, some images on the different stages in the TNM 8th edition classification. How to treat now thymomas? According to the NCCN guidelines, we as surgeons, we always look for the initial management. Is this a tumor that is completely resectable, or does it look locally advanced and unresectable? And then, of course, we will take tissue diagnosis for decision and further treatment. This is a rough algorithm for treatment. So the small thymomas, the stage 1 thymomas, we deal with surgery. For the more advanced stage 2 and stage 3, it's usually surgery followed by another therapy, mainly radiotherapy, port. And then in the really invasive tumors, stage 3 and 4, we start with induction treatment followed by surgery and sometimes followed by radiotherapy or chemotherapy. But there is no high evidence to support this treatment algorithm. Unfortunately, we need much more randomized control trials. So an example of an induction chemotherapy patient who received some cycles of a chemotherapy regime called ADOC. And you can see that the patient responded very well. There was nearly no tumor left prior to surgery. And so we did a thoracoscopic thymectomy in this patient. What is the golden standard for surgery? The principle is you need to aim for a complete excision, so take out the whole thymus and the tumor and all invaded structures. So what is our preferred incision? If it's a really big tumor, the best approach is a sternotomy, so a midline incision through the sternum. Or sometimes if the tumor is more to one side, we can do a thoracotomy incision. And in smaller tumors, of course, in the interest of our patient, we now prefer minimally invasive surgery, so-called video-assisted thoracoscopic surgery or robotic-assisted thoracoscopic surgery. So in surgery, we have to do a complete resection, so an en bloc total thymectomy, including all the mediastinal fat and the thymic tissue. And we take also vital structure whenever they are invaded, like the pericardium and the pleura, the phrenic nerve, the innominate vein, and sometimes we have to do a wedge excision of the lung or even take out the lobe, and rarely we do a pneumonectomy. Some examples of the different stages. This was a well encapsulated stage 1 tumor, completely resected thoracoscopically. This is a stage 2 tumor with invasion of the pericardium. So we took out a piece of pericardium. A stage 3A tumor with invasion of the lung, as you can see here. So we did a wedge excision of the lung together with the tumor, and then a stage 3A with venous invasion. So we replaced the veins, the central veins, with a synthetic graft. And then this was a patient with stage 3B with invasion of the heart structures and the big vessels going to the heart. So this was really major surgery with the help of cardiopulmonary bypass. And then finally, a stage 4A patient who presented with not only a tumor in the anterior mediastinal, but also with some nodules on the diaphragm, the so-called droplet metastases. And in these patients, it's always a discussion, what is the best treatment? Should we remove these droplets with local pleural resection, such as debulking, or do we need to remove the whole pleura and do a pleurectomy decortication? What is the usefulness of chemotherapy intraoperatively, or should we remove the whole lung together with the tumor and the pleura? And that is a discussion. And then finally, here is a case report of a patient with a big thymic carcinoma. He was 61 years old. He presented with pain between the scapula, and he had a palpable mass in the sternum. We treated him with induction chemotherapy, 4 cycles of CAP. The tumor shrank a little bit, and then we did an en bloc resection of the sternum and the tumor. We reconstructed the sternum, and then he was treated with adjuvant radiotherapy. So, and then, of course, we have to follow up all the patients who had surgery. And here you can see the guidelines, what to do in the years after the surgery to follow the patients and to have surveillance for recurrence. So, Mr. Chairman, I come to my conclusion. For the surgeon, it's important to have a good knowledge of the anatomy and to understand all the mediastinal compartments. It's also important to take into account the age and the symptoms of the patients to make a differential diagnosis of all mediastinal masses. It's important not to take a biopsy of a well-encapsulated tumor, but to do a primary resection. And when we do a resection, a complete resection is the most important prognostic factor for survival. We aim for thoracoscopic resections if the lesions are resectable and non-invasive, but for the more larger tumor and the invasive lesions, we prefer to do a thoracotomy or sternotomy. So thank you very much for your attention, and of course, I'm open to all your questions.
Great. Thank you so much for the excellent presentation. We'll now proceed to the Q&A session. I see some questions in the chat from the audience. And I think the first question is, I'll just read this. I'm curious if there has been any research on whether an autoimmune disease causes thymoma. Is there such a piece of evidence to support this? Or is it vice versa? Thymoma causes autoimmune disorders in some patients. I hope to hear from one of the speakers.
To my knowledge, I don't think there is evidence to explicitly say an autoimmune disease can cause transformation of a thymic epithelial cell into a sort of a cancerous tumor. The corollary is there's more evidence to substantiate it, of course, where, as we mentioned, there can be disordered T cell development in the setting of a thymic tumor, and that can lead to generation of these self-reactive, T cells, and that in turn can cause autoimmune disease. But I don't think the other way, not to my knowledge. I don't know of data that would support that contention.
Thank you very much, Dr. Rajan.
Yeah, I would agree with that statement. I don't think there's evidence to suggest that an autoimmune disease of any sort would induce a neoplasm, a cancer. So,
thanks, Dr. Kaminski. The second question we have is, I'll just read this. Patient with thymoma, with inflammation of the brain, having had all of the symptoms that Dr. Kaminski mentioned during his lecture. I'm wondering if when Dr. Kaminski said removing the tumor does not cure autoimmune disease, if he was talking about MG or other neurological complications as well. I had a thymectomy in July, have not had any major problems, and have not had anything noticeable long-term symptoms at all in the past 2 months or so. I feel like removing the tumor was the cure for me. Any comments, Dr. Kaminski?
yeah, so I would say, first of all, it's fantastic that you no longer have any of the symptoms that you had that brought attention to the tumor. And we certainly would hope that for every one of our patients. And as I mentioned in my lecture, I had one individual with myasthenia who had kind of minimal symptoms, had the tumor removed, 2 years later is fine. But the only thing I would say is we don't have enough knowledge to say that somebody is cured from an autoimmune disease once the tumor is removed. So even as you heard from Dr. Rajan, that you have antibodies floating in your system and yet don't have any clinical symptoms. So, that suggests that we can't say cure, but we can certainly say, remission from the autoimmune disease has occurred. And I think for you as an individual patient, that means the same thing. Don't worry about this, but be cognizant that you might have symptoms and be aware of those and talk to your physician about that. I mean, I'd like to know, even though this was specifically for me, I wonder what the other panelists might think.
I think there's certainly a subset of individuals who have demonstrable antibodies, but no clinical correlate. Whether that can be completely cleared, as Dr. Kaminski mentioned, is unclear. From an oncology perspective, I sort of broadly tend to think about antibody, and this is a very simplistic explanation, of course, but antibody-mediated disorders which may tend to improve, and as Dr. Kaminski mentioned, not go into remission, but not be cured in a way, but certainly with clinical improvement, as we just heard. And then the more T-cell oriented, disorders, pure red cell aplasia and things like that, where there is no correlation. And that is probably because you have T-cell memory and things like that, where the tumor is gone, but you still have the autoimmune condition. So I think there's a distinction that clinically that one could make, and you just have to track it and see how the autoimmune condition evolves.
Thank you very much for the explanation and insights. I think this question is for all the speakers, and so I think Dr. Ardeshir from Emory University, who's also a specialist in thymic tumors, asked, in patient with stable pleural mets in imaging for a while, a recent recurrence of myasthenia gravis, do you recommend surgery in pleural met removal to reduce the burden of tumor to see whether that may improve the outcomes of or symptoms of myasthenia gravis? Is this an approach that you would consider? I would ask Dr. Van Raemdonck first.
Yeah, let me tackle that question. It's always a discussion whether we should remove pleural mets, yes or no. But as a surgeon, speaking as a surgeon, when these pleural droplets seem resectable by, let's say, minimally invasive surgery with thoracoscopy, we would aim for resection. And in some patients, we have seen myasthenia gravis disappearing again. But sometimes, you know, you have patients with very small pleural droplets, hundreds of droplets, and then I don't know whether we should do more radical surgery, yes or no. But certainly if there is, let's say, 2-3 pleural droplets that can be easily resected, we would go for resection.
Yeah, and I can probably add to that from a medical oncology standpoint. It's the same principle, really. The question is the myasthenia now active because the underlying thymic tumor is active? And if that is the case and it's not resectable, then do you institute medical therapy? But one thing I would also point out, you know, we have I have been following a patient for several years now who had a thymic tumor. It was resected. He also had myasthenia, and that quietened down. And then after several years, the tumors were growing very slowly, but we know there were pleural nodules that we sort of just kept an eye on. There was a sudden flare of myasthenia, but the other aspect in this also was that he actually had an infection that preceded it. So the point being, infections, vaccinations, other immune stimuli can also upset the balance with these autoimmune conditions. And if you have necessarily such a preceding event, which might explain why the situation changed, then perhaps you just wait for it to quieten down or treat it rather than go and try to do an invasive procedure, which is exactly what we did there. And with the passage of time, everything quietened down. The myasthenia is being managed. There was no further medical therapy, chemotherapy, or surgery for the thymoma. So that's another aspect to just keep in mind in the equation.
Yeah, I think that's important to appreciate. You know, if you look at non-thymoma myasthenia gravis, so garden variety, so to speak, one of the clinical hallmarks is that you have fluctuations of the disease. And often, you know, 30% of patients, it's associated with infections or at times institution of a medication that affects nerve muscle communication. But sometimes it's spontaneous and we don't know. So you can have these fluctuations in non-thymoma myasthenia. And so it's not surprising to see that in thymomatous myasthenia, and whether those small tumors have anything to do with that flare is very difficult to say. And, you know, again, because of the rarity, you hear all of us talking about, oh, we had a patient that, you know, responded this way. I mean, each one of these patients is unique, and each one has to have their treatments tailored specifically. And so it's hard to produce broad answers.
Thank you. We'll try to go through probably 3 more questions here. So Dr. Edith Marom asked for Dr. Rajan, how do you conclude the patient has an autoimmune pneumonitis, not infection, when the yield from BAL bronchoalveolar lavage is so low? When do you do a biopsy, if at all, to prove it? So
yeah, that's a great question. Thank you, Chul and Edith, for that question. It's difficult, you know, and many a times these cases are misdiagnosed, either with an underlying structural lung condition such as bronchiectasis or cystic fibrosis, or, you know, something else altogether. So I think I've been very fortunate in that we have a group here at the NIH that works on this. They're actually from the National Institutes of Allergy and Infectious Diseases. We collaborate closely with them. I think the principle they typically tend to use is to look at the entire clinical picture and see if, what are the chances that all the features that you're seeing on the scans and clinically cannot be explained by an alternative diagnosis, whether it's infection or some sort of inflammatory condition, sarcoid or something else. One of the first steps they do, and I don't know if these assays are available on the outside, it's certainly a research assay even at the NIH, is we check for the antibodies. Because 60% of the time or so, you can pick up these antibodies in the context of these symptoms. So if you have serological evidence of antibodies to the bronchial epithelium, or the two antibodies specifically that we have found are associated with autoimmune pneumonitis, then it sort of declares itself, and we may not go around doing invasive procedures in those cases. But there have been instances where the serology may not be very suggestive, but the clinical picture is. So if you have other autoimmune diseases which can frequently occur along with this, or you're unsure, then you go ahead to either Dr. Merom's question, you go ahead and do a bronchoscopy, you get the biopsy, you try to see if there are lymphocytes, and that helps you, sort of plan the appropriate type of immunosuppressive regimen for these patients.
Great, thank you, Dr. Rajan. Two more questions. One of the questions was that we talked about lichen planus, this motility, pneumonia, bronchiectasis. I'd like to know which hospital system in the United States have doctors that are up to date on the research to help with the treatment. Well, NIH for sure, where Dr. Rajan is. Yes, any comment on this question?
Yeah, I think in terms of autoimmune disorders, it's really important to find a place that has the expertise. And in terms of these other autoimmune conditions, there are obviously several great places where folks have the expertise and treatment of these autoimmune conditions. These resources have coalesced together also in the context of immune therapies, and not just for thymic tumors, but there are programs that review immune-related adverse events, these sort of conditions. I know Boston has a group, for example, I think it was Dana-Farber, where they have a great group looking at immune toxicities. So I think these sort of resources are there in at least the big tertiary university hospitals, referral centers. As far as pneumonitis specifically is concerned, I'm afraid I'm not sure as to the presence of research groups elsewhere. But certainly, as Dr. Kim mentioned, at the NIH, we have, through NIAID, we have a group that has worked on this. They do it in the context of this condition, APICED, that I talked about, and associated issues, one of which is thymoma, as far as the AIR gene mutations are concerned. They certainly have the expertise.
Thank you.
And I will point out also, if I may just add, the antibodies, as far as I know, these are research assays that are done, and they certainly help for clinical purposes as well. I'm not sure if these are done on the outside or are there for regular clinical use. I'm just not sure.
I think this is our last question. This is about the pathogenesis of autoimmune disease in thymic carcinoma, as thymic carcinomas usually do not contain thymocytes. Is that possibly has something to do with the interaction between carcinoma cells and the thymocytes that may be in the surrounding residual thymus, not in the sort of cancer itself? This is a more sort of translational basic science question. Any insight from the panel on this question?
Yeah. If I can start addressing this question, I think this is a question for one of our pathologists. In my experience, indeed, patients with thymic carcinomas, they have another. These are different patients than thymoma patients. They usually have smoked a lot. Sometimes it's not easy to differentiate, is it the lung carcinoma invading the mediastinum, or is it the mediastinal tumor invading the lung? But I'm not a pathologist to say whether you can still see thymic tissue, yes or no, or whether it's just only carcinoma. But we have some pathologists here in online, but I'm afraid they cannot speak. Maybe Anya, if you are, yeah.
Actually, the question is mine. What I was wondering is what the pathogenesis of, there are these very rare patients with thymic carcinoma that also have autoimmune disease in the literature. And I was wondering what the pathogenesis may be in these patients, since the thymic carcinomas, as you said, Dirk, they usually do not have the thymocytes. I mean, there are maybe thymocytes in the surrounding thymic gland, but not within the tumor. So they are different than the thymomas. So I was wondering what may be the pathogenesis in these tumors.
Mhm.
And thanks for your presentations. That was very educational.
Thank you, Anya.
Yeah, I'm afraid I don't have an answer to that. I think there is work being done, some of it that I'm aware of, looking at these basic interactions between the hematological compartment and the epithelial compartment. I will say though that we certainly have had cases where, in the context of immunotherapy, where patients with thymic carcinoma have had autoimmune immune-related complications. Not something you would expect, but even in the pembrolizumab studies, 20% of patients had severe autoimmune complications, including myositis. So there's something certainly in the biology that we need to understand further. One other anecdotal observation of mine, of ours, and from our program is that there have been some cases, patients who have been diagnosed with thymic carcinoma, and consistently carried that diagnosis, who had, in one instance, for example, myositis, immune myositis, and it was treated and so forth. But at some point down the road, when serial biopsies were done, one of them returned with all the features of a B3 thymoma. So I actually wonder whether some of these cases might involve tumor heterogeneity, and just histologically, whether there may be perhaps that component that is not captured in initial small core biopsies. I think it's unlikely and rare, but that might be an explanation for at least a small number of cases. But there genuinely are cases of thymic carcinoma, as Dr. Roden mentioned, where we see this, and the biological explanation is still not 100% clear.
Great, thank you. I think that's the end of the session, and I'd like to express my gratitude to our speakers for your time and effort and presentations, and I'd like to thank the audience for participation and joining the session. And it was my absolute pleasure to moderate the webinar. I hope everyone found this educational as I did, and thank you all for joining, and have a great day. Bye.